Welcome to the Eye Clinic Sulzbach, where we'll have live transmission for the next 4 hours. And Karl will present a proliferative diabetic retinopathy in a 78-year-old woman. On the other eye, she already had 3 vitrectomies with silicone oil, quite a difficult situation. On the right eye now, it is a slightly earlier situation, but we have highly active proliferations. So, Karl, please.
Thank you for the invitation, Ziggy and Grazia. And I would thank also Dina and Lisa for assisting me, my nurses. And I will introduce today the OS4 UP. It's the world first live surgery with this new system from Oertli. And I would like to highlight the new Caliburn Trocar system. It's very interesting and an amazing 4-step in quality. And you see here the diagonal shape of the Trocar system, and that reduces the force to inserting for 40%. And you have here a little marking on the Trocar to have a good direction or the correct direction. And now I start, and you see how smooth this Trocar goes in. You see here the yellow valve, and it's now a 4-flap valve that makes a little bit more comfortable to get in the eye. And you can remove this valve also, it's not problem. And now we have a look to the new cutter system. It's now a 25 gauge cutter, and they improved the stiffness by 50%, and also the infusion line is adapted to a higher infusion capacity, and in 25 gauge we have 50% more infusion with this new Trocar system.
Karl, what is your visualization system?
It's an Artevo 850 with the OCT inside, and yeah. Thank you to Zeiss for this fantastic microscope. It's a very challenging cases here, but that's the reason why we choose it for you. And I have still a little bit problem to find the start for detaching the vitreous, and you have several adhesions zone here, especially in the upper part, in this temporal part, in upper and lower part, and especially here in the inferior part. And the whole vitreous is sticking on the retina, and it's very difficult to detach it without any holes.
Karl, this is only a traction detachment, is that correct? No regmatogenous component?
I think it's here a fibrosis, and the proliferations are more in this region here. And
but there are no holes there, correct?
At the moment, not. No holes.
And the macula is the macula involved or not involved?
Macula is quite okay, and that is the reason why the patient's always a little bit getting back too late in our clinic. So that is a quite positive sign for her. But the periphery is amazing here with this traction. And the vitreous is a little bit stiffer, fibrosis, and you see this traction here is sitting directly on the retina. And I will now change to the bimanual.
And this patient did not have any laser treatment before, huh?
Only here in the periphery. Here.
They have some laser.
Yeah, some.
Do you usually start dissection from the get-go, or do you dissect the hyaloid first? The mid-periphery round and then go after the scar tissue?
My typical approach is to dissect it in the periphery, and then I work to the middle, but it doesn't work here in this case. So I started here and have a little bit free area of the macula, and now I have to adapt my approach to go from the center to the periphery. And my typical approach is from peripheral to the center.
Great, we'll come back. And I think we have a question from the audience for Karl. Is that correct, Francesco?
Yes, hello. I'm installing the chandelier.
Is a question from the audience.
Yes.
Question is whether in this case, where the macula is not involved and apparently there is no regmatogenous part of the detachment, what is the specific indication for proceeding this surgery, and whether pan-retinal photocoagulation could have been sufficient?
I think it's, in this case, a very important thing that we stop the proliferation, especially the fibrosis. And we have, the macula is not absolutely okay. It's a little bit macular edema. And I think it's, we have to prevent further neovascularizations. And that's the reason why I prefer an anti-proliferative vitrectomy, and we are discussing all the time the time for these surgeries, and I think this is a little bit too late, but it's still useful for the patient to prevent more and more bleedings. She had a lot of bleedings, they resolved always, but in this case we have a very heavy proliferative case, and I think this is necessary to prevent.
Maria Antonia.
Hello, Karl. This is Maria Antonia. I might have missed during the presentation, but did the patient had anti-VEGF before surgery? And I'm interested in knowing if he modulate the duration, like the timing of the anti-VEGF based on the vascular or fibrotic component of the membranes.
Basically, when do you inject anti-VEGF? Did this patient have anti-VEGF injection before surgery?
Yesterday we did this injection, and you are right, that could be a little bit more in advance, but that is in our hospital not so easy to with the logistic, and so we decided to put it in yesterday, and but I think 5 or 7 days before could be a little bit better.
It's a great question. And you can actually do it up to 24 hours before, but the key is usually when you do it, make sure the patient has clearance for surgery, because the last thing you want to do is you do it like a week before, then the patient doesn't get clear for surgery, and if they're so fibrotic, then you get crunched, and then now they get a regmatogenous component. So usually within a day before, it helps. You can get less bleeding. And I think it was a great question from the audience. That was what I was asking also. When you have a lot of tractional component, if the macula is not involved, sometimes you can just monitor them and it may not progress. The key in this case is you also do very careful laser treatment. If there's so much fibrotic tissue they present to you for the first time, you don't want to do suddenly a 2,000 spot of PRP. You do divide it so that that fibrotic tissue does not contract. And then potentially it can be also monitored. Thank you, Karl. We're going to come back to you. Let's go back to Sulzbach. Karl, room 6.
Yeah, I'm happy to remove now the inferior proliferation, and I switched to the bimanual approach, and let's have a look. We have
Karl, I think we have a question for you.
Yeah.
Hi, Karl. Francesco again, about just delivering a question from the audience. The question is whether segmentation would be enough for such a patient instead of the membrane, the fibrovascular membrane.
No, it's
do you
not.
Agree, or you think that an extensive delamination would be better, and why?
I think it's very important to loosen the traction between these arcs, and the traction. You have several spots here, and I think it's very important to remove that. If there is still some around this spot without any traction, you can leave something. But it's necessary to remove the traction between these spots.
Roxanne, do you want to comment? And I think we need more microphones here if we can. We are fighting over microphones with the panelists.
I just wondered, what are you running the... Oh, here we go. I was going to ask what you're running the infusion, because I noticed the nerve is pulsing and quite pale, but you have some bleeding. But you're running, I think the infusion's at 30.
And again, extremely important when you do diabetic patients, also check for the blood pressure. You make sure the diastolic usually is around 80.
The blood pressure is 100 to 70. It could be a little bit higher, but the infusion is 30, and yeah, it's a little bit pale. But you see here the traction on the optic disc. I will remove it now, and I think it's improved a little bit the blood flow in this case.
Great comment by Roxanne. You know, as retina specialists, we are not really trained to look at the optic nerve as frequently as we should.
Yeah.
But it's really important during surgery, always monitor to make sure that optic nerve is perfused. Even if it's pulsating, that means half the time, if you operate for an hour, for 30 minutes, that retina was not perfused. Especially elderly, diabetic, so you want to keep an eye on it. Karl, we're going to come back to you. Back to Karl, who's also doing a diabetic case in Sulzbach.
Yeah.
Karl?
Yeah. Hello again, and I'm happy to loosen the superior traction, and that in a bimanual manner. And you see here the traction between this and this spot is now free or away. And now I can remove the remnants of the vitreous. And the vitreous is still sticking on the retina in the periphery. And I would like to loosen it a little bit more and shave the periphery to prevent PDR.
Karl, we have a question for you from the audience. Francesco?
Yeah.
Hi, Karl. Apparently your surgery is attracting a lot of interest. So the question is, how do you manage the fibrovascular stalks of the fibrovascular attraction point? Do you cauterize? Do you cut short? Do you remove at all?
No. At first I tried to delaminate the zone between this traction, especially nearby the traction where I can see that the retina is flat and I have enough space to go under the vitreous remnants with the cutter and try to separate it. If it is not possible and the cutter is not working, this vitreous, then I switch to the bimanual approach and have a scissor and the forceps. And then I try to grab it a little bit and go under and have the tension between the tissue and the fibrosis, and then I can cut there very easily.
Karl, you're quite popular today. We have another question from the audience from you.
Yes, this actually can be shared between you and Flavio, because the question is the management of the traction on the optic nerve, thing you're doing now, whether you are aggressive in removing that fibrotic adherence or you leave it. But apparently you're dealing with that.
Yeah.
Good timing for the question.
In the normal case, the proliferation of the disc are very easy to remove. But if you have a traction between the periphery and the center, you have to be careful to remove it, because you have then also traction on the peripheral part. So the normal situation is that you can pull it here easily, but you see in this case you have still traction on the vessels, so I have to remove it here in this case by manual, I guess.
Francesco, how do you usually do it?
Aren't you concerned about damaging the optic nerve fibers? I usually, unless there is a fibrovascular proliferation, if it's just fibrotic, I leave it like that, because I'm concerned about the traction on the fibers.
That's a great point. I usually remove it. I'm always concerned because if you leave it alone, then they come back 3 months later, you have an epidermal membrane growing from that fibrotic tissue. Yeah. And as Karl pointed out, also when you're peeling in diabetics, if it's a fibrotic tissue for TRD or over the nerve, you got to always be very cautious how far that fibrotic tissue is going, because you may be peeling on the arcade, but it's pulling on the fovea, and not suddenly getting a macular hole while you're peeling somewhere else. The same here. As he showed, when you're peeling on the nerve, you want to make sure how far that strand is going and where else are you inducing traction. Again, diabetics tissue can be very thin. You also have to be very careful when you peel at the nerve that you don't get any breaks in the retina. And then usually sometimes you need to go up on the pressure, because most of the times when you peel this is going to bleed. I usually leave this towards the end. If I can dissect everything, this would be the last thing I do. Sometimes dissection is difficult and you cannot get any planes. Then you go to the nerve. That's usually where you can start getting a... So Karl, I think one of the questions we had was, you have fibrotic tissue, but the fovea was not involved. There was no regmatogenous component. Why not just observe this patient?
I think the detached area creates in the inferior part and the superior part, especially in the bigger fibrosis parts. And it's not really clear to see, but there was a lot of traction on this, and especially the ring formation of the fibrosis is an indication for me to prevent further retinal detachment. I expect that comes in many months.
Grazie. Question for Karl?
Yeah, indeed, these patients can do well without surgery, but for sure, part of them can do well without surgery. But I think a patient like this one is safer off after a vitrectomy. If we remove retraction, you do a good laser, it will stay stable forever.
So, Grazie, how do you judge when to operate on these patients?
Early.
It depends a little bit when it comes in. Sometimes, probably, if you see such a patient and everything is fibrotic already, I would leave like this because you don't know when the problem started and made it stable. When you see some progression and you reach this condition after anti-VEGF injection, then I will proceed with surgery because it is likely to need more injection, more treatments, and you stabilize the patient after a vitrectomy.
Alistair?
Yeah, I think that to address that point specifically, Karl was operating on an eye 24 hours after Avastin. So what had happened is that the active vascular component had closed, and what we were seeing in the audience was what looked like possibly stable fibrosis. But 2 days ago, that could have been really active, red, vascularized, and going to progress, moving on to something worse. So it wasn't just potentially treating what was there, it was preventing progression of very extensive neovascularization, but we didn't see that because it was post-Avastin.
Yeah, so that's a great point, that the Avastin may mask how much vascularization you have. I think the other point to judge is you can follow the patient closely and see if this patient is progressing and getting worse, and if they do, then progress with surgery, and obviously how active the proliferative component is from the angiogenesis part and not fibrotic part. Gotcha, you want to come?
Sometimes these patients, you cannot follow them closely.
They
do not come back, they have other pathologies, they disappear for months.
And what ends up happening in these patients, as you said, over time, then the retina becomes really thin, and then they get a break, and then becomes a combined regmatogenous, and the vision drops, and then they show up to your office for surgery.
One comment from Sulzbach. I think you ignore a little bit the fluorescence angiography, and there's some very, very active neovascularizations, and the key is the early vitrectomy. I think this stage is a little bit late, and we have to prevent that the macula will be involved. So I think still that the early vitrectomy in diabetic retinopathy and proliferation cases is very important and have more success than the late stages.
Karl, is that the test where you inject the dye and take pictures? Is that the fluorescent angiography?
Pardon?
I was just joking with you. I think
no.
In a retinal practice, we do a lot less and less, at least in the US, we do less and less fluorescent angiography. You do a lot more OCT, but it's a great point that the fluorescent angiography can help you the amount of non-perfusion. Francesco?
Yeah, just for the sake of discussion, I totally agree on the idea of an early vitrectomy. We end up with much better eyes. But another possibility in this case, also taking into account that those kind of patients have a very poor compliance, I mean, they don't show up in the future, would have been a complete indirect laser photocoagulation.
Yeah.
So you get rid of all this ischemic area and possibly fibrotizing all those fibrovascular networks.
When do you do the laser? I mean, when this patient showed up like this, or before they developed?
No, just I would have taken the patient in the theater, giving a block, and then the indirect 360 degree. This is just for the sake of discussion.
Thank you very much for the invitation, and have fun in Munich.
Well, a round of applause for Karl from Sulzbach.